Inborn Errors Metabolism, Part 1, Module 2, Lecture 4 in the Genetics series, Amino acid, Organic acidemias, and Urea cycle disorders. Clinical presentation of metabolic disease can be very nonspecific. There can be lethargy, decreased feeding, vomiting. These symptoms can progress rapidly to seizure and coma. These are very similar symptoms that can be seen in many etiologies, including congenital heart defects as well as sepsis. So a newborn crash is defined as a healthy baby that then becomes lethargic and is very ill in a very short period of time. There's usually a well interval because in a metabolic disorder, the placenta is filtering the blood that the baby is unable to metabolize. Again, nonspecific, poor feeding, vomiting, lethargy, progressing to seizure and coma. Occasionally there's an abnormal odor to the urine. So, differential. You have a term baby, born healthy, looking good, and then crashes. The number one thing, the number two thing, the number 10 thing that you think about is sepsis. Sepsis, sepsis, sepsis. But when it's not sepsis, there are a number of other things that need to be considered, including adrenal insufficiency, congenital heart defect, asphyxia. Even though the baby has a well interval, if there was significant asphyxia, cells could be breaking down and show a little bit later. But in this period, we also need to consider metabolic diseases, including amino acid abnormalities, urea cycle abnormalities, organic acidurias, as well as mitochondria. This is a diagram. It's certainly not perfect, but it's one of the best I've found to try to look at this. So here we have the clinical presentation of lethargy, coma, seizures, vomiting, maybe abnormal odor. Is the baby acidotic? What is the HCO3? If the baby is acidotic, if it's less than 16, where is that acid coming from? Is it coming from lactic acid? As in the case of primary lactic acidosis, pyruvate carboxylase and pyruvate dehydrogenase, which are mitochondrial disorders? Or is it secondary lactic acidosis, which could include glycogen storage disease, tyrosinemia, galactosemia, even coarctation of the aorta? This is a congenital anomaly that can result in severe lactic acidosis. Or is it coming from organic acids, such as propionic acidemia, methylmalonic, MSUD stands for maple syrup urine disease, glutaric, and oxyprolinuria. If, on the other hand, the baby is lethargic but not acidotic, what is the ammonia? If the ammonia is elevated, it may indicate a urea cycle defect, which we have talked about, including ornithine transcarbamylase, aspartase deficiency, citrullinemia. And if all that's normal, it still could be a metabolic disease, including something called non-ketotic hyperglycemia, phenylketonuria, and then, of course, non-metabolic. So, metabolic acidosis, decreased blood pH caused by accumulation of hydrogen, decreased bicarb and excessive HCO3 and H2CO3, decreased PCO2 because of compensatory hyperventilation. Is the metabolic acidosis the result of abnormal loss of bicarb in the case of diarrhea, or the accumulation of acid? And this is when we use the Henderson-Hasselbalch equation to measure the anion gap, which includes plasma sodium minus chloride plus HCO3. This should be between 10 and 15. In metabolic disorders, there's an accumulation of organic anions. This results in a persistent elevation of acid or mild metabolic acidosis with intermittent acute metabolic decompensation. So here we have another diagram, metabolic acidosis. When we have a normal anion gap, this usually results from abnormal losses of bicarb, such as diarrhea or something called renal tubular acidosis, RTA. When the anion gap is expanded, this is an indication of accumulation of a fixed acid. Now, if we're talking about a 5-year-old, a 10-year-old, a 50-year-old, ketoacidosis is one of the most common causes of diabetes. However, in a newborn with an expanded anion gap, neonatal diabetes, while described as incredibly rare, and makes organic acidopathies and lactic acidosis being far more common. So when we're looking at these, it's very dependent on the age of the patient. Organic aciduria. This is a group of defects resulting known as organic aciduria. The clinical features include decompensation the first 2 weeks of life, can present later with a partial enzyme block, acidosis, elevation of the anion gap, elevated lactic acid, and hypoglycemia. The names of the organic acidemias include methylmalonic, isovaleric, propionic, and glutaric. It is not important to be able to differentiate one from the other. Common features include ketoacidosis, elevation of glycine on amino acids, hypoglycemia, and neutropenia or bone marrow suppression. They can also have mild hyperammonemia, which is usually due because of the hypoglycemia and liver disease. Aminoacidemias. Amino acids are building blocks of the protein. There are essential amino acids, and the remainder are converted between essential amino acids to other amino acids. There are a number of enzymes involved in these processes and breakdown of amino acids. Phenylketonuria, or PKU, is one of the most commonly described. The problem with phenylketonuria is phenylalanine cannot be converted to tyrosine through this enzyme phenylalanine hydroxylase. As a result, the phenylalanine is shunted to phenylpyruvate. While tyrosine is usually low, so if we looked at the amino acids in a patient with PKU, the phenylalanine would be very elevated, and the tyrosine would actually be lower. This is not really the problem because we get plenty of tyrosine from our amino acid pool. The problem is this very elevated phenylalanine is shunted to something called phenylpyruvate, and phenylpyruvate can be turned into a number of acids, including phenylactate, phenylacetate, phenylethamine, and phenylacetylglutamate, and these are toxic to the brain. Infants untreated with elevated phenylalanine can lose 50 IQ points in the first year of life if untreated. Here's a little video on PKU.
Phenylketonuria, or simply PKU, is an autosomal recessive disease in which there's a problem in one of the enzymes involved in the metabolism of phenylalanine. Now, before we look at the details of this particular disease, let's take a look at the actual metabolism of phenylalanine as it takes place in normal individuals. So as we ingest food that is rich in protein, the protein is broken down into individual amino acids. And one of these amino acids is phenylalanine. Now, about 25% of the phenylalanine is actually used to build new proteins inside our cells. But the remaining 75% phenylalanine is used in the liver to actually generate another amino acid known as tyrosine. Now, tyrosine is also used to generate new protein because we need 20 amino acids to generate protein. But the remaining unused tyrosine inside the liver is metabolized via these steps into acetoacetate and fumarate. Now, acetoacetate is transformed into ketone bodies, and fumarate is transformed into glucose. And the cells of our body can use the ketone bodies and glucose for energy. So that's the normal process of metabolism of phenylalanine as it takes place inside our body. Now, what's the problem in patients with PKU? Well, by definition, phenylketonuria basically means high levels of phenylketone, also known as phenylpyruvate, in our urine. Now, where do we get phenylketone from? Well, when we have accumulation of phenylalanine inside our body, that phenylalanine is transformed into phenylketone, also called phenylpyruvate. And so we see that the problem in these patients is elevated levels of phenylalanine. And the only way that we elevate levels of this molecule is if this reaction does not take place at a high enough rate. And that's exactly what the problem is in patients with PKU. The problem is within this step. So we have phenylalanine that is transformed into tyrosine by this enzyme. So phenylalanine hydroxylase is a mixed function oxygenase that uses a cofactor known as tetrahydrobiopterin. Now this is not a vitamin. It's a cofactor that is built inside our cells, inside our body. So if there's a problem within this enzyme itself, or there's a problem in actually building this cofactor, this reaction will not take place. And so the person will develop phenylketonuria. Now, the most common cause of phenylketonuria is a defect in this enzyme. And this is an autosomal recessive disease. What that means is the patient, to have PKU, has to get a defective gene from the male parent and a defective gene from the female parent to actually develop symptoms of phenylketonuria. So carriers of this disease essentially grow up to be normal. Now, if we have high levels of phenylalanine, what will that cause? Well, high levels of phenylalanine will essentially affect the myelination of the neurons inside our body, inside our brain. And so high levels of phenylalanine will essentially cause defects in brain development. In fact, people with PKU have low IQs. Now, this is a very dangerous condition if not treated. In fact, about half the patients with PKU who are not treated die before the age of 20. And about 75% of the patients that are not treated die before the age of 30. However, if we treat this condition early on and continue the treatment throughout the lifetime of the individual, that individual will essentially grow to be normal. Now, how do we treat this problem? Well, essentially, the patient that has PKU before birth, they have no problems. Why? Well, because the mother has the enzyme to actually catalyze this step. And so any phenylalanine within the mother will be transformed into tyrosine. Now, following birth, there's also no problem. Why? Because that patient has not yet ingested protein rich in phenylalanine. But as soon as that patient is born and then is fed, they essentially obtain the protein, break down the protein into phenylalanine, and then they cannot transform the phenylalanine into tyrosine. So now this phenylalanine will begin to essentially accumulate within the blood and tissue of that patient. And so this is precisely how we can actually diagnose a patient with PKU. Because patients with PKU after birth and following the first feeding cycle will have levels of phenylalanine that are 20 times higher than those of normal patients that don't have PKU. So by drawing blood and finding high levels of phenylalanine in that infant, we essentially can diagnose that infant with PKU. Now, how do we treat this patient with PKU? Well, essentially, we have to limit protein intake, and we limit specifically phenylalanine. So we give just enough phenylalanine for that patient to be able to build new protein, but we have to limit that phenylalanine because the patient can transform that phenylalanine to tyrosine. So to summarize, phenylketonuria is essentially a condition in which we find very high levels of phenylketones inside our urine. Why? Well, the problem lies within this step. Usually there's a defect in this enzyme, phenylalanine hydroxylase, so we can't transform phenylalanine into tyrosine. And so we're going to build up phenylalanine inside that individual. The phenylalanine will be transformed into phenylpyruvate, also known as phenylketone, and that will begin to appear within that urine of that patient.
Next, we're going to go on to urea cycles. The purpose of the urea cycle is to dispose of nitrogenous waste and make the amino acid arginine. When the cycle is not working correctly, ammonia can be very elevated. The incidence of urea cycles, fortunately, is rare, 1 in 30,000, with the X-linked ornithine transcarbamylase being the most common. So we're going to go through the urea cycle. And basically, the purpose of the urea cycle is to take ammonia and excrete it in a water-soluble form called urea. The first step, these first two steps that we're going to talk about in the video occur in the mitochondria, but carbamyl phosphate goes into the urea cycle by getting attached to ornithine to make citrulline. When this enzyme is not working right, that's known as ornithine transcarbamylase. And as stated, this is inherited in X-linked recessive fashion. The next step is citrulline goes to its original succinate by adding in the aspartate. When this enzyme is not working, the citrulline gets very elevated, and that's what's known as citrullinemia. The next step is an original succinate makes arginine through this original succinate lyase enzyme. Once it's deficient, then this is elevated and arginine is very low. And the final step is arginase. Arginine releases urea, which is water soluble, and returns to ornithine. This is X-linked. The rest of these are rare recessive disorders. The mildest is the arginase deficiency, which can actually present later in childhood with elevated ammonia and something that looks like spasticity, or it's in the masqueraders of cerebral palsy. It looks like cerebral palsy, but it's actually a urea cycle defect. So symptoms of urea cycle defects, because of the accumulation of ammonia, the patients with urea cycle defects are often alkalotic. As we've talked about, a lot of the inborn errors, organic acidemias have acidosis. The ammonia can reach a very high levels, to thousands. So here we have another video to go through some of the more details of the urea cycle.
Urea cycle is the process of removal of ammonia from the human body. Ammonia is an end product of protein metabolism. It is toxic to the human body, especially the central nervous system. Therefore, it has to be removed from the blood by converting to a harmless water-soluble compound called urea. This process of detoxification of ammonia is called the urea cycle. If we look at the structure of urea, the two nitrogen atoms in urea is derived from two different sources, one from ammonia and the other directly from aspartate. The carbon part comes from carbon dioxide. Urea synthesis is a 5-step cyclic process with 5 distinct enzymes. The first two reactions occur in the mitochondria because the required enzymes are present in the mitochondria, whereas the remaining cycle takes place in the cytosol. Now, let's look at the two steps that occur in the mitochondria. The first step is the formation of carbamoyl phosphate. Carbamoyl phosphate is synthesized from ammonia and carbon dioxide in the presence of the enzyme carbamoyl phosphate synthetase 1. Carbamoyl phosphate synthetase 1 requires activation by N-acetyl glutamate, which is the positive allosteric activator of this enzyme. N-acetyl glutamate is synthesized from acetyl coenzyme A and glutamate by N-acetyl glutamate synthase. So this step consumes 2 ATP and is said to be an irreversible and rate-limiting step of this cycle. The next step is the formation of citrulline. The carbamoyl part of carbamoyl phosphate is transferred to ornithine by the enzyme ornithine transcarbamylase to form citrulline. Ornithine and citrulline are basic amino acids that participate in the urea cycle, moving across the inner mitochondrial membrane via a co-transporter. The following 3 reactions now occur in the cytosol. The third step of this cycle is the synthesis of argininosuccinate. The enzyme argininosuccinate synthetase combines citrulline with the amino acid aspartate to form argininosuccinate. As discussed earlier, aspartate here provides the second nitrogen that is ultimately incorporated into urea. It is important to note that the third and final ATP in the cycle is utilized here. The next step is the cleavage of argininosuccinate. The intermediate argininosuccinate is cleaved by the enzyme argininosuccinate lyase to yield arginine and fumarate. Fumarate produced in the urea cycle is hydrated to malate that can be utilized directly or indirectly in other metabolic pathways. The fifth and final step is the formation of urea. Here the enzyme arginase cleaves arginine to ornithine and urea. Ornithine is transported back into the mitochondrion in exchange for citrulline, where it can be used for another round of the cycle. This last step occurs almost exclusively in the liver because the enzyme arginase is present primarily in the liver. So whereas the other tissues such as the kidney can synthesize arginine by these reactions, but only the liver can cleave the arginine and thereby synthesize urea. Urea, which is formed, then passes into the blood and is transported to the kidneys where it is filtered and excreted in the urine. A portion of the urea diffuses from the blood into the intestine. Here, it is decomposed by intestinal bacterial urease to carbon dioxide and ammonia. This ammonia is partly lost in the feces and is partly reabsorbed into the blood. Through the portal circulation, majority returns to the liver where it is detoxified back to urea, while a small portion of ammonia goes back into the systemic circulation. The urea excreted each day by a healthy adult is about 30 grams and accounts for about 90% of the nitrogenous excretory products produced by our body. And by the way, did you know that the urea cycle was the first metabolic cycle to be discovered? It is known as the Krebs-Henseleit cycle, named after the scientists. As ornithine is the first member of the reaction sequences, it is also called as the ornithine cycle.
Next, we're going to go to some cases as examples. So in case 1, a 3-day-old, and this is important how old the patient is, presents to the primary MD for routine follow-up after discharge from the nursery. He was born full-term, normal spontaneous vaginal delivery without complications to a 32-year-old G1P1, so this was her first child. All serologies were negative. The group B status of the mother is unknown. The mother states the baby's having difficulty breastfeeding, and she wonders if she should change to a bottle. The mother also notices that the baby throws up a lot, and he has a sweet smell to his urine. The baby has lost 7% of his birth weight. The physical exam is normal. 4 days later, the baby presents to the emergency room unresponsive and hypertonic. His eyes begin to deviate and he begins to convulse. So looking at the laboratory, the blood pH is 7.34 with a CO2 of 15. So the baby is acidotic. The ammonia is 180, mildly elevated but not significant. The lactic acid is 1.4. So this acidotic state is not coming from lactic acid, so all these things can be eliminated. The glucose is 70, so the baby has some hypoglycemia. So the baby deteriorates in the first 1 to 2 weeks of life. The ammonia is normal to mildly elevated. The lactic acid is normal. The glucose is normal. And there's a sweet smell or maple syrup smell to the urine or urea. This is a very uncommon disorder, but very common in the Mennonite population and inherited in autosomal recessive fashion. This is maple syrup urine disease. Unfortunately, as a geneticist, I'm chased after by the nurses in the nursery with a number of diapers that I try to run from. But some of these things are important. So if there's a sweet smell to the urine, think of maple syrup urine disease. Sweaty feet, isovaleric, and tyrosnemia, rotten cabbage. I fortunately never smelled rotten cabbage, and I hope not to. Here's our second case. A baby boy was born by C-section. His APGARs are 9 and 9, and APGARs are what parents think is the first birth, report card, but really it's just how active the baby was at birth. At 36 hours of life, he appears hypotonic and lethargic. He has low temperature or hypothermia. His blood gas indicates the pH to be 7.49 with an HCO3 of 26. Septic workup, including CPC and lumbar puncture, looking at the spinal fluid, of normal. So we get pneumonia, and it's 1500. As stated earlier, normal is less than 60. So we have a lethargic baby with some vomiting. He's not acidotic, but his ammonia is very elevated. So it's probably one of these. And again, the goal is not to be able to differentiate one urea cycle to the other, but to understand when you have one. So this is the urea cycle. The most common, especially in the male, is the X-linked ornithine transcarbamylase. There are, as we were stating, 4 enzymes. So a 4-day-old presents with lethargy, decreased PO intake, and a blood pH of 7.49 with an ammonia 1200. What is the most likely diagnosis? Galactosemia, medium chain acylcarnitine deficiency, maple syrup urine disease, ornithine transcarbamylase deficiency, or phenylketonuria. This concludes the lecture on inborn errors of metabolism, organic aciduria.